Thank you. At the outset, I would like to thank Dr. Ramurthy for giving me this opportunity. And my topic is top pulse in posterior polar cataract management. We all know posterior polar cataract is a rare form of congenital cataract, and the incidence of posterior polar cataract is around 3 to 5 per thousand cases of cataract we operate. And the most common problem what we encounter is posterior capsular rupture with the subsequent nucleus drop due to abnormal addition of posterior capsule to the polar opacity. And there has been a significant improvement in the outcome. The PCR rate has come down drastically in the last couple of years. This could be because of the better understanding of the condition, better diagnostics we have, and improvement in the surgical skills of the surgeons. So now the posterior capsular rupture rate is roughly around 4 to 6%. I'm going to show a series of videos of phacoemulsification in case of posterior polar cataract. We had a long discussion in the previous session. We had almost half an hour discussion on posterior capsular cataract management. Here, we are making a moderate sized rexis. This is around 4.5 to 5 millimeters diameter. This is just because, and then injecting fluid. This is a hydrodelamination, just going just below the rexis margin and injecting fluid into the substance of the nucleus. And I usually even delineate with the Sinski hook so that my nucleus will be free in the bag, epinuclear bag. And then emulsify the nucleus. This is a very soft cataract, and maintaining the chamber is extremely important. Inject visco whenever we come out of the antechamber, and now the epinucleus is separated from the cortex by again a jet of fluid which separates it, and you aspirate the epinucleus and try to maintain a chamber throughout. And inject visco whenever you come out. Don't allow the AC to collapse, and do a 360-degree cortical cleanup using a bilateral bimanual irrigation aspiration cannula, and inject the lens into the bag. There is a small debris. I'm not going to touch it. It's in the posterior pole. And again, emphasis on hydrodelamination. So you stay in the substance of the nucleus at the junction of the nucleus and epinucleus. You create a gap here by injecting a small amount of fluid, and then try to inject fluid in that gap. So you get a nice golden ring. You can even do multi-quadrant hydrodelamination. Slowly inject a little amount of fluid and try to separate it completely from the epinucleus. Then it becomes easy for you to manipulate this nucleus. And this is a technique. The other technique which was described by our own Dr. Vasevada, inside out technique, where you create a trench and then inject fluid into the walls of the one of the wall of the trench, and that will delineate the nucleus, and then you can follow your routine step. This is a case, it's a moderately hard cataract. It's not as soft as the previous cases, and I'm trying to do hydrodelamination here, but I was not able to be successful. So I'm planning to do a mechanical delamination, and using a Sinski hook, just delaminating the nucleus from the epinucleus. It's a grade 2 to grade 3 cataract, and then you do your chopping technique, in situ chopping, and try to separate the heminucleus from the epinuclear cushion, and do all your manipulation in the cover of epinuclear cushion, and using moderate parameters, I usually complete the procedure. And this actually has led to me doing a new procedure. This is a mechanical delamination. I have started doing it more often now, and this is um, the depiction of the same. You have a clay model here. So we are going to delineate the nucleus from the epinucleus using a Sinskey hook or a chopper, and then you emulsify the nucleus. The similar procedure of delineation of epinucleus from the cortex is done. Once that is done, you either emulsify or phacoaspirate the epinucleus, and then do your 360-degree cortical cleanup and inject your lens into the bag. So in this way you are completely avoiding any hydro procedure which you usually do, so that the accidental seepage of fluid into the subcapsular capsular space can be avoided. This is a soft cataract, grade 1 to 2 PPC, and I am doing a mechanical delamination using a Sinskey hook. So I am delineating endonucleus from the epinucleus, and now trying to delineate epinucleus from the remaining cortex, and doing a phacoemulsification, chopping, and doing the emulsification part within the capsular cushion, epinuclear cushion. Do a layer by layer aspiration of epinucleus, cortex, and cortical cleanup. Follow all the other parameters which you usually follow, and maintain the anterior chamber. Don't allow the AIC to collapse. This is another case. The AIOS-OCT shows there is a defect in the posterior capsule, and this is the case. Again, it's a very soft cataract, but the patient was symptomatic. It was right in the center, and it was progressive in nature. So went ahead with the phacoemulsification, and I have done a mechanical delamination. No hydro procedure was done in this case. Since it's a very soft cataract, I could aspirate it. The epinucleus was aspirated using IA, and then you can see the defect here. It is a small defect which is actually fibrosed defect. There is a hole in the posterior capsule, and you could maintain it. It has not enlarged during the maneuvers, and you could place the lens in the bag. It is a multifocal toric lens which was implanted into the bag, and it's stable. No vitrectomy was needed because there was no vitreous prolapse. Another case of PC defect. This is an obvious PC defect here, and this is the case. You could see the debris of cortical debris in the patellar fossa, and this is the case. And again, I did delamination, mechanical delamination, moderate sized rexis, and very soft cataract. You can aspirate it. That's what I have done here. You can see a defect here. This is a PC defect, but there is a lot of debris, and in the anterior vitreous face. This patient definitely requires a anterior vitrectomy, even though there was no obvious vitreous prolapse from the capsular defect. And I'm doing a posterior capsulorhexis. And the rhexis, the posterior capsulorhexis is completed, and the lens is placed in the back. This is again a multifocal toric lens. The lens was injected into the back. Once you have a posterior capsulorhexis, it's easy for you to manipulate. So the lens is very well placed, and it's stable post-operatively. You can see the posterior capsular rhexis margin, and this is anterior capsular rhexis margin. Another case of posterior capsular defect, this particular patient, when I injected visco into the antechamber, I could see a split happening. And this is the split that has happened during injecting of visco into the antechamber. And so you have a posterior capsular tear right from the beginning. So one has to be careful, and I did a mechanical delamination and layer by layer removal of the cortical material, and there is a vertical split which was extending from the limbus to the limbus, and did the anterior vitrectomy. This is an old case, so I have not used tricot here, but I could place the lens in the back. So, to conclude, one has to be very careful while handling a case of posterior polar cataract. You have to do a thorough slit lamp examination to see the posterior capsular status, and if you have access to anterior segment OCT, you have to assess the posterior capsule and avoid any positive pressure during surgery, and provide a closed chamber during all the stages, and maintain the contours of the cornea and globe, minimize turbulence and pressure in the anterior chamber, prevent iatrogenic PCR and or extension of pre-existent PC defect, mechanically cushion the polar opacity throughout, and reduce your parameters while doing the surgery, and avoid capsular polishing. Thank you very much.
Thank you so much, Shreesh. I mean, I think you nicely brought out all the various aspects of posterior polar cataract management. Recently, we have conducted a study, and our approach towards posterior polar cataracts has gone a sea change with the use of anterior segment OCT. Dr. Tamiyarisi actually did the study, and I would like her to comment on this, how AIOS-OCT has impacted our management of...
No.
Good evening all, and we know that preoperative use of AIOS-OCT in polar cataracts has a high negative predictive value. It means that if the posterior capsule is traced beyond the opacity, it is unlikely to rupture during the intraoperative period. And Titial et al. Sir has demonstrated in a study in 2020 itself that using intraoperative OCT, he has identified a low risk variant where they have done hydrodissection, and out of the 19 eyes, he has reported no instance of PCR. And in the study, they have correlated that preoperative AIOS-OCT image correlated with the intraoperative OCT image. So, talking of hydrodissection in PPC, though it looks controversial, we took the scientific evidence of these two what is there in the literature, and we designed a study where he used preoperative AIOS-OCT, and if the PC could be traced beyond the opacity, we did a gentle hydrodissection and nuclear rotation. And if the PC could not be traced beyond the opacity, we did hydrodelineation and did not do any nuclear rotation. And we had around 56 eyes in the type 1 PPC, and we had only one PCR, and in the second group where the PC was not intact, we followed all the routine precautions, and we had 4 eyes of PCR, which was statistically significant. And the negative predictive value with hydrodissection in our study was 98.1%. Whereas the positive predictive value was 25%. It means that not all cases where the PC was not traced had PCR. It could be because of the dense polar opacity, which has not allowed us to image the posterior capsule. So these was study results.
Dr. Abhay, any comments? You have been always mastering PPC.
I must say I didn't understand everything, but
I agree that intraoperative OCT, if you have it and if you practice it, you can use it. Professor Titial has shown it and their group, and you are doing the same thing. But from a general surgeon's point of view, and I don't have intraoperative OCT, I don't use it. If you have a posterior polar cataract, and even if you're scanning a scan or whatever shows intact capsule, I would not hydrodissect. We never know, because I have had the bad experience where the whole surgery is over, everything is there, and you just hydrate the incision and the capsule ruptures. So do not trust. I don't trust posterior polar until I remove the speculum out of the eye. It will rupture any second. So if you have this kind of a controlled imaging and you have experience, go ahead. But I would be reluctant to suggest everyone, it's better to err on not doing it. You can always do it if you need to do it some stage in the surgery. That's my general comment. But I didn't understand what you were saying. It's my fault. I didn't attend that much. I'm sorry.
This was the general concept, and that's what we are practicing for almost 3 decades. Recently with the AIOS2025, not the intraoperative OCT, but the SSOCT, Swepsos OCT used for AIOS2025, we're able to get a very clear delineation as to whether the posterior capsule is intact or not. It's as Dr. Vasavada pointed out, it may be intact, but still there could be, it could easily give way. So all your maneuvers have to be quite gentle, but we have started hydrodissecting these eyes where the posterior capsule is intact. And as Dr. Tamil pointed out, just in 1 case out of 56, we had a PCR in these cases.
I think, the important thing is you need to have a high definition OCT, because earlier generation OCT will not give you a good picture. So if you have a high definition anti-segment OCT, gives a very nice delineation of all the structures, morphology of posterior polar cataract in relationship to the posterior capsule. Even those cases what Dr. Abhay was talking about, if I do hydrodissection also, I will not rotate the entire the bulk of a complex. I'll again delineate. You have a core of a nucleus. You maintain the epicortical cushion till the end without disturbing that. So you have a very easy time to remove that epicortical cushion, because most of the time the damage to posterior capsule happens when you are trying to remove the epicortex. If there is a fluid delineation, it comes out very easily and you prevent the disruption happening. That people should understand.
Excellent.